Next up, I'd like to introduce Darryl back to the stage for his third and final talk. He's come a long way, so we thought we'd make the most of him. He bridges the gap quite nicely between John talking about data and Emma, who's up following Darryl. Darryl's going to be talking about identifying dying people using data.
Thanks, Alex. This is a very dry talk about a very nuanced and sensitive topic. So I've been asked to how we use data to identify dying people. So it's not quite like this, although some of our clinicians have a sixth sense, I think, when it comes to predicting who's going to become unwell and die on the ward. So just quickly, I'm going to talk about how often patients die in the hospital, a bit about trajectories, which Alex has talked about, dying the deteriorating patient, and then predicting death in hospitals, and then the most important and practical thing, 5 ways to use data to identify dying patients. So how often do patients die in hospitals? And this is actually not a statistic that's really that widely published. The two I've got from our region are the HOPE equation from Graham Duke. That's now quite old, that's 2009. And that showed that about 2.5% of patients in Victoria died over a 1-year period in 380,000 admissions. And a study that we did, we're a tertiary unit, so and we looked specifically at patients that stayed more than 24 hours, and about 4% of those patients died. So it's almost always less than 5%, but that's still quite common, 1 in 20 patients. So these are trajectories of death that Alex has alluded to. So this is sudden death due to trauma or an acute overwhelming illness. This is a rapidly progressive cancer. This is the sort of thing that I think we can have the biggest impact on, because patients can have a relatively predictable trajectory interrupted by periods of deterioration with variable recovery. And I think we can start talking to them back here. And this is the patient who has a frailty type condition or a neurodegenerative type condition. And increasingly, people are using data sets to actually model these trajectories and look at who falls into each of the categories. And I presented this yesterday, but this, in that group where there is a predictable decline, I think we can start talking about 1 year when patients come to hospital but they return to independent function, 1 month where they have increasing debility, increasing hospitalisations, and they may actually die during one of those hospitalisations, and then the last week, in which they do obviously die in the hospital if it's their last week. And advanced care planning, palliative care services, and the rapid response team and ICU come in at those varying phases. But as we've talked about a number of times, it's relatively easy to look at it from this perspective and go backwards, but that's not what clinicians have the benefit of. It's always to be wise in hindsight. Instead, what clinicians see is this. They have a patient who's unwell, who develops abnormal vital signs or other signs of deterioration, and it's difficult to know whether the deterioration is reversible, in which case the aim is to avoid morbidity and mortality, or it's irreversible, in which case the aim is to provide good symptom control and spiritual care in the broader sense of the word, and ensure dignity is maintained and the patient has a good death. Because in this group, early intervention and aggressive therapy is what's desired, whereas in this group, early recognition of a dying patient and avoiding such therapies, which I'm increasingly calling non-beneficial rather than futile. I think futile has a value judgment associated with it, is the aim of the game. But in both cases, and you've heard this a lot of times before, you need to provide the right care in the right place at the right time. And in one occasion it's palliative care setting or the ward with limits of treatment and comfort care if there's deterioration, and in the other it might be a high dependency or a intensive care. So can we predict who's going to die in hospital from data? And the answer is sort of. So this is now, as I say, quite old, and this is the HOPE equation that Graham Duke worked on. This is published in the Internal Medicine Journal, back in 2009, and they used the VAED, which I alluded to earlier, and they found a number of variables that were associated with increased risk of death. You won't be surprised that age, primary diagnosis, the requirement for an into-hospital transfer, admission from an aged care facility, that's where they were living, and an unplanned admission, and gender were the final predictors. And I've alluded to ECART, which is Dana Edelston's program from Chicago in the United States. Again, they've got a model which has a relatively good area under the curve. Just to put the statistic in perspective, if you flip a coin, the area under the curve will be 0.5. And so anything above 0.85 is extremely good. Anything above 0.9 is extraordinarily good. 0.7s and 0.6s is what you usually see in statistical models, and they're okay, but as you can understand, 0.6 is not much better than 0.5, and that affects the sensitivity and specificity of the test. But we always say that when you've got a model, it applies to a population. You cannot use a mathematical model to apply to a single patient because you can't be 70% dead. You're either dead or you're alive. What the model tells you is you've got a 70%, you belong in a population that has a roughly 70% risk of death, if that makes sense. All right, so here are my 5 ways, and I'm going to keep it short and sharp. We can use big data, as you've just heard, but that's really out of the realm of the average clinician, and you really need complex clinical informatics teams, data warehouses, biostatisticians, and a lot of dedicated resources. Dana Edelston's ECART costs $100,000 per year for your hospital to run. It's sort of a lease type thing, and a massive amount of infrastructure. So the 5 I'm going to give you are relatively simple and straightforward, and within the realms of what we can do in our hospitals. So the first thing to do is audit your resuscitation plans, and we've heard people talk about that already. Do you have a policy for completing it? You should probably have a policy as to guide people when they should complete it, and if so, how often is it completed, and is it in compliance with your policy? It's very difficult to be critical of your staff for not completing a form if you've not given them guidance about when to complete such a form. And so we're the leaders, we're all leaders in this room, and I think I would encourage you to do that in your hospital. Are they completed in patients who have died? And what's the timeliness of completion? You don't want to see a resuscitation form that's completed and revised multiple times very close to death. That suggests that there's lack of clarity and ambiguity. You want them completed at the time of or shortly after hospital admission, and ideally under the supervision of the most senior clinician available. This is not something you want your junior medical staff doing. Clearly things change with time, so it's dynamic. But you do not want your not for CPR, not for ICU, to be completed at a Met call. That's a crisis. You do not want that to be the case. Okay, so that's the first couple of ways. The next one is to audit your end-of-life care Met calls. A lot of us now have medical emergency team databases, or we collect them manually. You could either do this in a statistical way or in a much richer way by looking at a random sample. We know that about a third of Met calls have end-of-life care issues. These patients have an extremely high mortality, and I've told you today that we have a couple of units at our hospital that are overrepresented. Orthopaedic surgery, general medicine, renal are the 3 major groups that are quite overrepresented with end-of-life care Met calls. You can encourage them to audit their own Met calls to see whether they could have done advanced care planning and end-of-life care planning better. We have in our database tick boxes to look at limitations of medical treatment before and after the call. You could look at the nature and quality of palliative care interventions that are given. You could look at whether there was agreement or disagreement between the medical emergency team members and the usual treating clinicians. and you can look at their in-hospital outcomes. And they could be crude, or they could be quite subtle and nuanced, looking at the quality of death, which you can predefine. So that's another way you can use data to look at the nature of dying. This is quantitative, but I also would argue it could be qualitative. You can use your morbidity and mortality meetings, and everyone should have these. And so this is how you can use data to look at dying. This is a saying I love from the leader of the Health Roundtable. One of the limitations of this approach is that the clinicians who provided the care are often the same clinicians who decided whether the death was preventable, which is obviously not ideal in a lot of morbidity. So it needs to be peer-reviewed. They need to occur regularly. It needs to be transparent and open. You ideally need to have a standardised tool. You shouldn't be judging them in isolation, because you're always going to potentially look at yourself quite favourably, unless you're the kind of person who likes to blame oneself. They should be free from blame and focus on learnings and the quality improvement cycle. And you can look at them objectively to see whether the patient on the trajectory to their death actually met criteria, for example, and was there compliance with your processes of escalation. So this is an example. We have this is, I think, the best M&M process we've got in our hospital. It's the Surgical Audit and Review Committee. Every week there's unit meetings with internal review. Every Thursday there's a very robust discussion about patients who die or have morbidity, and notes are documented by quality coordinators. And then there's a standardised tool which is presented to a higher order committee called the Surgical Audit and Review Committee. And the details aren't important, but here's an example. And these are, was it a coroner's case, was it an autopsy, and have a lot of predefined things. So this puts some semi-objectivity in relation to the nature of a patient who dies. And there's just as there's in our deteriorating patient committee, an escalation tree for the committees. From the Thursday morbidity and mortality meeting, it goes to SARC. If there's perceived problems with care, it goes to a further committee, which has physicians and anaesthetists and quality coordinators called the Patient Review Committee. And if there's a big problem, it can go to executive and legal. And we like to close this loop. So there's standing items on every month so that it's reviewed the next time to make sure that what we recommended actually comes back. So there's different colours in the text we put with each patient. The next one that you can look at is your own in-hospital cardiac arrests. And this is relatively simple because there's not relatively few of them, hopefully. And there's already national and international bodies that are recommending that we should do this. And so these are two Australian, and that's the International Society of Rapid Response Systems. You need a mechanism to collect them. The vast majority of teams have ICU involvement, but if you don't, you need to tailor it to your hospital. The simplest question is, how many do you have? And it's staggering how many hospitals cannot answer that question. Everyone knows how many code blues they've got because that's audited at Switchboard, but to know the precise number of patients who receive cardiopulmonary compressions or DCR or electrical cardioversion for a non-perfusing rhythm, that sort of detail is much less frequently known. So how should you audit these? Well, there's very detailed templates with the Utstein template. That's an international agreement. If you've got all the time in the world, knock your socks off. From the perspective of what I think is important, I think you should look at the demographics and comorbidity and functional status of a patient, because if it's not so good, that poses the question, should the patient have even received cardiopulmonary resuscitation? What sort of rhythm it is? So last year in our hospital, we had, I think, 4 or 5 patients with shockable rhythms on the ward. The vast majority of in-hospital cardiac arrests are asystole and PEA, and that has implications for training of your BLS and ALS team. So we now have initial and expert responders, and we do not teach ALS to every doctor in the hospital unless they're going remotely. Because in our hospital, we have about 1 shockable rhythm every quarter. What was the quality of the resuscitation? And these, I think, are the most important questions if you want to look towards the potential preventability of the cardiac arrest. Were there warning signs, early warning score, or met criteria, and was the team activated? So you can call this afferent limb failure, I guess you could call that. So in summary, the mortality of in-hospital patients is somewhere in the order of 2 to 4%, and we've talked about 4 trajectories of death. I think the most useful one is the gradual decline with recovery, because that's a lot of the patients who die in our hospitals, and that's the one we can intervene 12 months out when they get the diagnosis of a life-limiting illness. Although predictive equations do exist, we should not use them to dictate treatment, but to inform conversations that we have with patients, because predictive tools do not perform well on an individual patient. They're designed for a population. We've talked about 5 ways of using data to identify dying patients: big data, audit of your resuscitation plans, audit of your end-of-life care met calls, M&M meetings, and your in-hospital cardiac arrests. And all of these processes need to be transparent, open, and have a process for escalation if there are concerns. And you need to try and make sure that you have a PDSA cycle so you have learnings from these, and you need to make sure you have processes to make sure you close the loop, that you learn from these things so that lessons are learned and problems aren't repeated. Thank you very much.